Chelsea.
Is under here? It's not here. Freedom.
Ma'am, yeah. Oh.
Where is your friend?
Ma'am, yeah. I'm the one talking since.
Oh, okay. You guys are sharing phone again.
No, ma. Separate.
Oh, okay. So, today we're going to be treating QT interval, T wave, and then U wave in ECG, and we're going to be starting with QT interval. Freedom, please. When it's 20 minutes, let me know so I can stop this thing. So, first, you already know what QT interval is, and even during these last days, I'm supposed to be asking you guys questions that people are supposed to be answering me. Well, we'll get into that as we progress. Yeah. So the QT interval represents the total time for ventricular depolarization and repolarization, because it's from the beginning of the QRS complex, which stands for ventricular depolarization, and ends at the end of the T wave, and T wave stands for ventricular repolarization. So the QT interval is the total time for ventricles to depolarize and then repolarize. So Okpe, Xander, if I'm correct. I don't know if you are.
Ma.
What does depolarization stand for? When something is depolarizing, what does it mean?
When something is depolarizing, Abi.
Yeah. What's the term I told you guys? It's just a simple word.
It's contraction.
You know, you people are in the same room, so I can hear whatever is telling you.
Eh?
I can hear what freedom is telling you. It's contraction, Abi. Ele. So yeah, you are right. It's contraction.
Yes, ma.
While repolarization means relaxation. So the normal duration for your QT interval, as we have been doing since when we started these waves and intervals, we have the normal and then we have the abnormal. So the normal duration for this QT interval is, first thing you need to know that is it varies with heart rate, right? The shorter sorry, the shorter your QT interval, the faster your heart rate. Please take note, because I've told you guys this thing before. The shorter your QT interval, the longer your heart rate, and vice versa, which means that the shorter your heart rate or the slower your heart rate, the longer your QT interval. It's just like opposite, right? So now, because this QT interval varies with heart rate, that's why we had to use corrected QT interval, which is the one that is the QT interval regardless of the heart rate of the person, right? So now, no, we don't. So now, for males, less than 440 meter, is it millimeter per second abi meter per second abi milliseconds, and females is less than 460 milliseconds. So can someone convert that for me? Can you divide it by 40 and let me know what you have? Divide both of them by 40. Oh, let me know what you have. Oh,
440 divided by 40 is 11.
okay. 460 nko?
Hey, 11 points. That's 11.5, yes.
Okay. So that means we're having 11 small boxes and 11.5 small boxes. And I'm sure you know why we are dividing by 40. So now QTC is actually has a formula. We call it the Base formula. And this formula we already discussed before, if you guys remember. Now QTC is basically corrected QT interval. The C stands for corrected, like I said. And the formula is the normal QT that you got over square root of R to R, square root of the number of boxes between R to R. Let's say your QT was 15 small boxes, and then your R to R interval, you counted, you had like 5 small boxes. Square root of 5 11 over square root of 5. That's your corrected QT interval. So we use corrected QT interval because that one is independent of the heart rate. You know, I said that the normal QT varies with heart rate, and then because someone is having slow heart rate, fast heart, because of those differences, we decided that we should come up with they decided that they should come up with the corrected QT interval that's going to calculate it regardless of the heart rate. Now, the clinical importance is that prolonged QT interval can be predisposed to torsades de pointes, which is a type of ventricular tachycardia. I don't know, we did this when we were talking about arrhythmias. So, prolonged QT interval can actually be a symptom of ventricular tachycardia. And let me show you, because I know you've forgotten, what ventricular tachycardia is. Let's see. Oh my gosh. Cause mo mọ̀ pé ẹ ti gbàgbé bẹ́yẹn. Ventricular tachycardia. Oh my goodness, who is that?
Tipa, you have not forgotten now.
Who is that? Oh, you have not forgotten. I see. Okay, I hope so. So this is an example of ventricular tachycardia, and you can see that the Q interval here is not even prominent. Normally, ventricular tachycardia, I told you, they are bizarre. Can you see now? I don't know if you guys are seeing what I'm trying to show. I've shown you this. I think this was the exact one we used. Let me see. I think it was the exact this thing I showed you guys. Some of you even came across it in your test. Was it test or exam? That you were giving me nonsense this thing, interpretation. If you kill a patient, don't tell them it's me that taught you, sha. You don't should not talk me back. I don't know why my network is not. Amen. Well, I don't know what's wrong with it, but this is ventricular tachycardia, prolonged QT interval is a symptom. I'm not saying someone that has ventricular prolonged QT interval, like I don't know how to even explain, but don't confuse it. It is a symptom of ventricular tachycardia. Now, another thing you need to note is now. So shortened QT interval can indicate hypercalcemia. Hypercalcemia is simply too much calcium, and I don't think you should really bother with that because that's not going to be your business when you are doing real life work. So now let's look at some of the causes of QT prolongation. We have some medications, electrolyte abnormalities, we have congenital lung QT syndrome, myocardial ischemia or infarction can also be a cause. And this is one of the clinical correlation. This one is not, you don't really have to dwell too much on QT interval. It's really rare, right? It's a very rare thing. But then your business to count the duration, how many small boxes it is. If it's more than 11, more than 11.5, then you know that there's actually a problem. Maybe myocardial ischemia and myocardial infarction, and it's just one of them. Okay, there are other things. You use your ST segment, your T wave to calculate your ST depression to see if it's ischemia or infarction. And ECG shows prolonged QTC. Further work up. You see that they had to do a further work up to reveal that this person is having hypokalemia and recently antipsychotics, blah 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 blah. What I'm just trying to tell you is that you should be concerned about the duration, and most of the time actually it's not going to be too long, because I mean, for something to be longer than 11 small boxes actually is a kind of a big thing. So, and also once you see that the person has QT interval, you should not jump to conclusions that it is myocardial ischemia or infarction, because there are other things that you also have to use, like I taught you in ST segment. Now we're going to do some of them in this T wave. Now T wave represents ventricular repolarization, right? ventricular repolarization. I've told you over and over and over again. Now, the normal features is that it is upright in most leads except AVR and then sometimes V1. Also, another thing you need to know is that it is normal in if it is less than 5 small boxes in the limb leads and less than 10 small boxes in the precordial leads. Now, one thing you also need to know is that your T wave must not be longer than the preceding QRS complex. I don't know if that oyinbo ko ye yin. It must not be longer or taller than half of the preceding QRS complex. It must not be taller than half of the QRS that is coming before it. You have a QRS, right? You're supposed to have a T wave. Let's say your QRS is tall by 10 small boxes. Your T wave must not be taller than 5 small boxes, which is half of the QRS complex. Okay? Your T wave must not be taller than half of the preceding, not the one that come after, the one that is coming before it. And also another thing you need to know, an abnormal P waves. Tall P wave, that means the one that is taller than the preceding QRS complex, that is taller than half of the preceding QRS complex. It shows any sign of hyperkalemia. Hyperkalemia means that high potassium. Hypercalcemia is calcium. Hyperkalemia is potassium. Now, flattened T wave, when your T wave is just flat, you're having hypokalemia and or myocardial ischemia. So it's further tests that is going to reveal which one you are actually having. And then there are also cases that your T wave can also be inverted. That one is myocardial ischemia. Now, I don't think you should worry about the biphasic P wave. And now, they are telling you a clinical correlation now here is that a tall T wave in all precordial leads in a dialysis patient may indicate what? Hyperkalemia. Look at what I said about abdominal T waves and their meaning. Peaked T wave, that means a T wave that is taller than half of the preceding QRS complex, it is hyperkalemia. Inverted P wave, myocardial ischemia. Flat P wave is also myocardial ischemia or hypokalemia. Now, do you understand up to where I am now, please? Nobody is in this call. Okay.
Yes,
I hope everybody on. I can hear you. Eh?
The factor is divided by 40 where you calculate 50.
Yeah, I said divided by what? 40. Oh, the person I said divided by 40. You don't understand?
Yes.
We are using 40 because going back to our 0.04 seconds. 0.04 seconds that we did at the beginning in calibration. Do you understand now? We just converted it to milliseconds times is it 100? I'm coming. 1 2 times 1000, sorry, millisecond times 1000 because the 440 is in milliseconds. That's why we have to do over 40. Do you get it now?
Okay.
All right. So moving on, what we are going to do today is just conclusion of everything we are going to do. The next class is just going to be we're going to be identifying different streams just to for your exam and also to prepare you for real life this thing. So now your U wave now. The definition of U wave, there's P wave, Q, R, S, then T, then U. But the U is not usually prominent. It's not prominent. You might not even see it. Just small some I'm coming. Let me see if I see it online so I can you can see that it's not really prominent. For you to see U wave on ECG, so it's more it's almost flat. Have you checked yours? You have what? Oh, okay. So now can you see it now? Is almost tiny. This one is even this thing. Can you see how tiny it is? Can you guys see what I'm showing you?
Yes, ma'am.
Okay, so it's really tiny. Your U wave is tiny, usually not prominent, it's just there. Okay, so now the normal features now it is best seen is used to represent repolarization of the Purkinje fibers, and it is best seen in V2 to V3 and usually small, like I said, usually less than one small box, and then is after the T wave. Now the abnormal U wave is when your U wave is now prominent. Your U wave is already getting to more than one small box. Like you already notice that this U wave is more than one, getting to two, getting to three. That one is abnormal. Usually associated with hypokalemia, which is low potassium, bradycardia too, and when you use drugs now. An inverted U wave is now a sign of ischemia, just like inverted T wave here. Inverted T wave here was also showing us myocardial ischemia. Inverted U wave can also be a sign of myocardial ischemia. Now, a patient with vomiting and present with muscle weak, ECG showed flat T waves and prominent U waves. Now, you see, flattened T waves now is hypokalemia. And what? Prominent U waves. And prominent U waves is what? Hypokalemia too. Right? And now that's what I told you. It's not ischemia. Why? Because now they said flat T waves is also ischemia, but because the U wave is prominent, the U wave is prominent, that is also showing us a sign of hypokalemia. So they already have those two symptoms in common. That's why we cannot say it's ischemia, because just T wave cannot be used. These things, one wave cannot just be used to identify these illnesses because they are more serious than the same. When it comes to doing myocardial infarction, in ischemia, those things, because they are actual heart attack. So you need to be really sure, because before you diagnose your patient of the wrong thing, and then the doctor is going to prescribe, because the doctor is going to work on what you are giving him, and then it's going to prescribe different drugs for the person, and then it's going to work in a antagonizing way. So now the tips for ECG interpretation now: always check your heart rate. Reading: first thing first, check your heart rate. After I check your heart, now determine is it regular or irregular rhythm. Check it. If it's irregular, now check your lead 2 first. Check the P wave, check the QRS complex, check the T wave, check the S wave. Normally your machine is going to give you results. The machine is actually going to bring a result for you. But your job as the cardiac physiologist is to be able to say, okay, this machine is wrong. Let's print again. So sometimes we go to the extent of using pen to write the person's results, because sometimes the machine can be malfunctioning. Sometimes your patient might be scared and the heart is going to be beating too fast. These are like a real life application. Sometimes the baby is shaking. Sometimes your patient is not stable. Sometimes your patient is having one disease or the other tó tiẹ̀ tí ń bá yí tẹ́lẹ̀. Sometimes your patient heart is on the left side, so on the right side, because I've seen a girl who came to do ECG, and she had to tell me that her own chest is on the left side. I've forgotten what they call it, but her chest was on the left side. But even with that ECG, we had to do our ECG on the normal places, on the normal place. Instead of a normal person's heart to be on the left, and then we take it from the right side to the left side. Our own chest that was on the right, instead of us to do it on the right side, we also had to do it on the left side. But then I think we didn't get an accurate result, so we had to compare both results. We did on the right side, they also did on the left side. Some people have undergone surgeries, some people are pregnant, some people have hypertension. So you need to consider all of these things before you actually diagnose your patient. So now in next class, I think what I'm going to be doing is that we are going to be doing a revision of everything that we have done. Okay, we are going to be doing a revision of everything that we have done. It's going to be like an hour longer for us to revise everything that we have done. Then you get to ask your questions and all of that. Is that fine? Okay, we are not going to do revision again. Don't worry. It's like if people
Ah,
get
revision is important. Very, 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 very
No, not
important.
division, no.
so
Not
this
Revision.
topic.
division, no.
Can you imagine? Ele. So next class here, Okoyemi is okay. I've heard you. Thank you very much. So next class we're going to be doing revision, and this class is a short class. Like I said, we don't have more. We just have to do the conclusion of everything that we have done before. And last week you didn't have your test. We are going to be having a test this week on Friday, and I will implore you, please pay up your money before Friday. And then your certificate, the designer is almost done with your certificate. So I'm going to send Freedom to you to get the names of everybody. And your exams, I'm going to come next class, we're going to communicate how you are going to do your exam and then your projects. Okay. So this we have come to the end of today's class. I'll see you guys. I'll
Ma'am,
send
I
you
want to say something. Ma'am, I want to confess my sin.
confess.
Hey, ma, see, I want to say that. Can you please take us again how to identify the waves, the ECG this thing
No
strip?
problem. I'm going to do revision. We're going to do revision class next week. So we're going to
Okay,
do
thank
all
you.
of that.
Because I will not lie, all those details that
Oh my dapo, ekpele. Celestina, do you want to ask a question? You can unmute your mic.
Yes, ma'am. Good evening,
Good
ma'am.
evening.
Yes, that's a question because I remember when I went for IT,
Okay.
there's actually like there are some patients that will be around that 15, 16 years old because I was told that there is difference between like when you are carrying out the procedure,
Yeah.
there's difference between the way you do it to someone that is around 18 to 18 above. So in a situation whereby maybe someone that just this generation, there are some young people that when you see them, you need to think like they are 18 or 20, meanwhile they are just 40, 50. So what if maybe someone did not actually tell you the age before and you already carried out the procedure, like you just use like normal adult, you didn't do the results like a child, like
Okay, I
you know
get
there is
you.
difference.
I
There
get
be
you.
any like alteration there because they used to tell us we should do for adult like any person that just came for ECG test and we actually notice that the person is having pimples, this all this kind thing. So we used to do like adult one for the person and normal
Okay.
like pediatric patient.
Okay.
So my question is that is it when the doctor are trying to read those results, is it the two they will just compare and contrast or they will just focus on that adult since the girl is like 15 years old and she's looking like someone that is 20, 21,
20.
22.
Okay. First thing I need you to know is that I don't know whether the machine doesn't accept age, but the first thing that you are to ask your patient after the person's name is the age. Everywhere that I have practiced, everybody I've done for, the first thing is to ask. The second thing after the name is the age. The age, not even the age, the date of birth of the person. Then you calculate because some old people don't remember their age. So you you ask for the person's age. So that can help you, even though the machine does not record the age of maybe the person, there's no space to impute the person's age, but you as the physiologist can actually ask for the person's age. And about the comparing and contrasting, well, that's where asking the patient's age comes to play because you can't just assume in this thing. It can be an easy test, but it is delicate. So you can't really assume. And also from the result, there are some patients that we've had to give them two results because both results were kind of like we did it over and over and over again, and then we're getting two different results. So we had to give them the two, and then the job of the doctor was to, ask them symptoms, the patient's symptoms, and then judge which one goes best with the results. But coming back to a summary, you have to ask your patient's age. So do you get?
Okay, thank you, ma.
Yeah.
Yes, ma. Please, I just want to take an excuse because on Sunday, the next class, I'm having comprehensive exam on Monday, comprehensive physiology, and everything from 200 level.
Oh,
So I might not be able to attend Sunday classes with revision
okay, we can
because we
do
have
Saturday. Will you be free on Saturday?
Jesus. Time,
Don't worry, don't worry.
ma, you
I
can.
understand, I understand. don't worry. I get how exams can be stressful. But you are going to meet the recordings for sure, don't worry. You meet the recording and then you can always ask me questions. So Esther that was asking how we got to the end of the class in 20 minutes. That's a very, very good question to ask as someone that came to the class late. I told you I was going to be starting class by 8:30. You are coming in by what? 2 minutes to 9. Káàbọ̀, you are going to meet the recording. I want to parí class. So today was just like a conclusion class, okay? So that's why we didn't too much. And next week is our revision class. Okay, I'm not going to tell you to attend the class. If you like attend, if you like don't attend. But I shall attend so that you get to ask all your questions. Except Celestina, of course. So bye guys. I'm going to see you with your test on Friday and then on Saturday for our class. Have a lovely week and pay up your fees. I beg you. Thank you very much. Good night.
Okay, ma. Thank you, ma. We love you for ma.
I
Thank you
don't
for
love you.
understanding
Oh gosh.
that this night is a very important night. You are the best, ma.
Hold up.
My team is leading 3-0, ma.
Ah,
My haters are
thank
crying.
God for your
Good night,
Alright,
ma.
good night. Oh God. God selected these students.